Dr. Girish Rao, Dr. Jyotirmay Biswas, sir. It's an honor to invite Dr. Jeevan Titiyal, sir, head of RP Center, AIMS, New Delhi, and Dr. Rohit Shetty. So we'll start with the first presentation.
Can you please give us the sheet, please?
Dr. Arvind Maurya.
Yes, boss.
ये सब पिछले शीट का मार्कशीट ये भी पहले
Shall I start? Have a very distinct. So,
Dr. Arvind Maurya, sir, will be speaking on orthoptech, magnocellular stimulator, a novel innovation in the management of amblyopia. Dr. Arvind, sir.
Thank you, sir. And good morning, respected judges and all my dear friends. So I will be speaking on our innovation, that is orthoptech magnocellular stimulator, a novel instrument for the management of amblyopia. So all these traditional, conventional management of amblyopia, they are very tedious and very problematic. And sometimes they also cause the reverse amblyopia in the better eye. So it's real time to think beyond the conventional therapy. So the answer is orthoptech magnocellular stimulator. So what is the hypothesis behind it? So impulses from the retina, it goes to the optic chiasma and then through the optic tract to the LGN, it ends along with the optic radiation in the V1 area of the occipital cortex. And here the 4C alpha, so the magnocellular cells, they sends a discharge here, and 4C beta, the parvocellular cells. There is dichotomy in the visual pathway. So from the retina magnocellular, they are responsible for the peripheral area, goes to the LGN1-2 ventral area, and the parvocellular central area, they goes into the 3, 4, 5, 6 LGN dorsal area. And now the inherent connections are there. So parvocellular going into the layer 4C beta in the V1, and the magnocellular, they are going into the layer 4C alpha in the V1. So these attention and saccadic, they have reciprocal action against them. But this 4C alpha, they have, because of their horizontal connection, they have positive stimulation towards the 4C beta parvocellular layer. So these repeated stimulation of the magnocellular cells, peripheral cells via the attention area and parietal cortex leads to stimulation of fovea, and these prosaccades are associated with maximal stimulation of the V1 area that is most affected in amblyopia. So this is how it is done. There are 3 rows of LED. So patient is asked to sit 1 meter behind and follow these light with the help of the green laser, these lights comes on and off for 150 millisecond. So we did the world's first clinical trial between Fakical versus Occlutev versus Orthoptech. So results were really good in all the three category, but when we compare the contrast sensitivity, it was maximum in Orthoptech group with a significant p-value as compared to the other groups, and also stereo acuity in Orthoptech group with a significant p-value as compared to the other two group. So in conclusion, Orthoptech magnocellular stimulator is a novel instrument in the management of anisomyopic and isomyopic amblyopia in terms of faster improvement in contrast sensitivity and stereo acuity for faster achievement of binocular single vision. And amblyopia is a brain abnormality. As you see in the upper picture is a functional blood oxygen level dependent MRI in a normal patient. And the second picture is of a amblyopic patient. So there are structural deficit in the visual cortex, and the functional MRI scan, they show a drastic reduction in the oxygen consumption in the cortex of amblyopia patient. And after treatment of the Orthoptech, there was the oxygen supply and the blood supply increased. Thank you so very much. And the innovator is with us, Dr. K.S. Santhan Gopal from India.
Thank you. The judges, please.
Just one question. You are talking about anisometric amblyopia. What about the strabismic amblyopia? Has
Yeah, it is
same role?
Yes, it has same role. Also, the degree of strabismus has also decreased as per one study done by Dr. Santhan Gopal and the rest of the authors. So degree of strabismus also decreased. There are 12 uses of this Orthoptech magnocellular stimulator in nystagmus also, and in the attention deficit, the children also, Alzheimer patients. So it has 12 indications.
So just one thing, there is a connection between the parietal and to the temporal cortex also. So if there is any functional dysfunction in the parietal cortex, will it affect the
Exactly.
stimulation thing? Okay.
Exactly, it is a problem in the brain.
No, that I understood. I'm
yeah.
saying if there is a lesion in the parietal
Definitely.
cortex, so
Yeah.
will this affect your therapy?
No, it doesn't
No.
affect our therapy. No.
Any more judges' question?
I think you talked about functional MRI in these cases. If you look into long-term results, will they sustain the
Yes.
changes happening in these cases?
Recurrence is not there, sir.
Okay.
It's sustaining for 9 months. In few of my patient, we doesn't require this therapy.
Okay. But what about the younger patient where you require much more attention in these cases?
So we are sitting with them. Yeah, it's a major problem. They were not improving, but when we started sitting with them, they started responding well.
Good, very nice.
And it's hardly 20 minutes therapy. It doesn't take much time. So we can make them concentrate for at least 20 minutes. Thank you, sir.
Thank you,
Thank
sir.
you so very
I'd like to request Professor Jivan Titial, sir, to please give a certificate of appreciation to Dr. Arvind Kumar. Next, we would like to invite Dr. Parthasarthi Roy, and he will be speaking on a novel study on timolol maleate 0.5% eye drops as a potential agent for presbyopia correction. Dr. Parthasarthi, sir.
Good morning, everybody. I will be presenting my innovation in novel study on timolol maleate 0.5% eye drop as a potential agent for presbyopia correction. I am Dr. Parthasarthi Roy. I have no financial interest to disclose. In recent times, there has been interest among researchers to develop pharmacological agents to treat presbyopia. However, only pilocarpine 1.25% eye drop has been approved by US FDA till date, but there is some inherent problem with pilocarpine eye drop, like compromised distant vision and narrowing of visual fields. We hypothesize timolol maleate 0.5% eye drop to have such properties as would be able to treat presbyopia at the same time overcome the side effects of pilocarpine. Intrinsic tone of ciliary muscle is maintained by mutually opposite interaction between parasympathetic and sympathetic. The parasympathetic tends to contract and sympathetic tends to relax the ciliary muscle, therefore blocking the sympathetic innervation. By instilling beta blocker drug like timolol maleate 0.5% eye drop will increase the tonic accommodation and therefore may be helpful in treatment of presbyopia. This mechanism spares pupillary muscles, thus do not have any effect on pupillary diameter and also avoid side effects of multi-drug combination which are currently under investigation. Moreover, by use of timolol maleate, distant vision is not affected. So our aim is to determine and compare the near point of accommodation and amplitude of accommodation of the subjects before and after instillation of timolol maleate 0.5% eye drop. 40 emmetropic subjects of ages between 35 and 45 were randomly assigned them to binocular once only, instillation of 1 drop of timolol maleate 0.5% eye drop, intervention group 20 subjects and control group 20 subjects with normal saline eye drop. For every subject, BCBA, IOP, near point of accommodation measured by Royal Air Force rule and amplitude of accommodation calculated from NPA were noted prior to giving eye drop and then at half an hour interval up to 10 hours. This is the result. In this graph, the graph of 20 subjects has been depicted, and immediately after giving the eye drop, there is the near point of accommodation coming progressively nearer to eye until 4 hours after instillation, when it is stabilized and maintained for 8 hours. Here, a single graph of the mean of 20 subjects compared with the control. This is the result of the amplitude of accommodation. Here, immediately after giving the drop, there is increase in the amplitude of accommodation, and that is stabilized at 4 hours, and up to 8 hours this remains. Here the mean value compared with the control. So, near point of accommodation maintained a steady state between 4 to 8 hours of instillation at point closer to eye by an average of 5.79 centimeter. This tantamounts to presbyopia correction of plus 1.21 diopter sustained for 4 hours between 4 and 8 hours after instillation of drop. There was no blurring of distant vision and no statistically significant lowering of IOP. So our conclusion was 1 drop of timolol maleate 0.5% drop instilled binocularly can achieve correction of presbyopia to the extent of plus 1.21 diopter sustained for 4 hours between 4 and 8 hours after instillation of drop. Thank you.
Thank you, Dr. Parthasarathi. Judges, please.
Very nice study, few things are, I want to check, once you talk about increasing the amplitude of accommodation in these patients of range of 1.21 diopters.
Yes, sir.
Will there be a change in the absolute refractive error in these cases also? You said distance and vision was not changed at all.
No, sir. We have checked the distant visuality. It is remaining the same. We took the emmetropic subjects, first of all.
Because
so
these
it remains emmetropic even after giving the drops.
These are young.
There was no change.
Your group of patients are very young, 35 to 45.
Yes, sir.
And emmetrophs, up to age of 40, they can manage, And their as such amplitude accommodation is so high. I don't know how much effect beta blocker will do in those cases. And these young patients, did they have some systemic change also? Did you look into other aspects also of side effects of beta blockers in these cases?
No, sir. First of all, we have given 1 drop of timolol maleate and taken the result. 1 drop of timolol maleate once binocularly. This is a pioneer study. This study has been taken in the world for the first time. With
Yeah,
the
yeah.
timolol malleate, no study has been taken as yet. So we
apart from-
wanted to make
no,
it
no.
sure that there is no
Okay.
safety issue.
Good,
first.
good. Apart from the, the measurement you have done, nowadays, all those studies which people are doing with the pilocarpine, they do a, dynamic anti-segment OCT pixelization of change in the lens and
Yes, sir,
anti-gamma
those are
profile.
there. But we have employed the simplest thing. And you will find that there is 20 graphs. All the graphs I have shown the equal, the similar pattern. So, this is a very unique thing about my study.
Okay.
The result.
Any more questions from any judges? Thank you, Dr. Parthasarthi.
Okay.
I'd like to request Dr. Vineet Ratra sir to please give a certificate of appreciation to Dr. Partha sir. Next, we would like to invite Dr. Debashish Datta, who will be speaking on negative dysphotopsia, a futuristic approach. Dr. Debashish, sir.
Yes, just thank you, AIOC and the respected judges. I'll be talking about this burning question of negative dysphotopsia, which follows a futuristic approach, and it is in the immediate uncomplicated phacoemulsification in the postoperative period. The incidence is as high as 12 to 45% as stated in the literature. It comes down later to about significantly, but in the immediate postoperative period it is high. There's optical factors, secondary factors, and neuroadaptation which goes into its understanding. There's a temporal crescent-like thing, Hod's blinders, which occurs due to in the immediate postoperative period when the bag is transparent, when it becomes opaque, then the scotoma goes away. Now the burden per year, considering the fact that India does 83 lakhs in a year, at 55% of it, 55 lakhs is a phaco, so 15% of that tantamounts to 8.34 lakhs of ND in the immediate postoperative period, though it may come down to later on. So what are the management strategies? The management strategies are many, of which two seems to work: the reverse optic capture and the bag to sulcus exchange. So you bring out the IOL from the bag and place it in the sulcus. So we have Dr. Samuel Muscat manufacturing an IOL whereby the optic is partially in the bag and partially in front of the rexis. So points to think under the apple tree. So we do maneuvers like sulcus placement of the IOL. This compromises the effective lens position and the centration, and reverse optic capture brings out the sharp optic edge in front of the rexis margin, leading to iris chapping and pigments release, blah, blah. So what is the solution under the apple tree? So I think of placing the haptics in the sulcus and capturing the optic in the bag below the rexis. This is a small video. This is the anterior haptic going below the iris in the sulcus. The second haptic is being dialed in the same place. And the optic, we nudge the optics below the rexis margins at the two ends, two semicircular areas. I mean, one more, the second haptic, and then the optic is negotiated below the rexis margin. So this is the postoperative period in retroillumination. We have this is the rexis margin, optic below it, and haptic in front of it. So in due course of time, it may be opacified, but that does not cause any harm. So we did a study where by 5 millimeter rexis and was done, and the uneventful phacos, and a telecolor used to call it on the 2nd, 3rd, and 90th day postoperatively about the negative dysphotopsia. To our surprise, we found that in the immediate postoperative period, the incidence of negative dysphotopsia in our case were 3.5% only vis-a-vis 15 to 45 or even 67% reported in the literature. If it is a solicited call, you ask the patient that and this 3.5% is we ask the patient actively that are you having this, rather than depending on the patient reporting it. So, and it comes down to 0.2%, 0.4% later on, these are not important. So what is the aim of the study? The reduction of negative dysphotopsia through strategic IOL placement is possible, and future innovations and IOL designs can be based on this. So we have ignored this negative dysphotopsia for a long time, ever since we're doing uncomplicated phaco within the bag placement of the IOL. So it will go away. That's what we say to our patients. But these days, where there's a flurry of premium IOLs, and we promise the sun to our patients. So if they are dissatisfied, I think the industry will think how to do away with this negative dysphotopsia. And now I think the time has come. These are my references. Thank you.
Thank you, Dr. Devashish. Judges, please.
Very nice presentation. First of all, the calculation of a percentage of Indian people getting this negative dysphotopsia may not be correct. You talked about 83 lakh surgery being done in India.
According to 22-23.
Of that, 80% are SICS, and they are all hydrophilic lenses. And we know that negative dysphotopsia are normally seen with the square lenses in the bag.
Hydrophobic
so you have
acrylics,
left with
that
only
is-
20% of cases. Of that, percentage will be less.
Okay.
That's okay.
Okay.
Second important thing is, now if we shift to your theory of putting multi-piece lenses the way we are putting, that means we are negating the advantage of multifocal lenses of these patients at this present time. Because we don't have the multifocal lenses or trifocal lenses in this design. So we may have to think in that direction also. Third point is, you're shifting the lens implantation, the effective lens position is going to be, anterior to the what normally we calculate. So that
Yes.
part we have to look into also, how to look into new effective lens position for the newer generation IOL power calculation. Other important thing will be now you putting a distance between the bag, that is the posterior capsule, and the IOL. So you'll have a very high chances of
PCO.
posterior capsular opacification or some sort of fluid collection happening in these cases because you have space. If you remember, there's a beautiful surgical techniques by lady Tessinganon. She does the in the back implantation where she does both anterior and posterior capsular axis and put the lens in capsules into those areas. So in your technique, maybe in future we take out the entire posterior capsule and we fix the lens like this, which may take away the
can I answer
PCO
that?
happening in future.
Can I have answer them?
Yeah, yeah.
So here we are defining we have taken it that the plane of placement is the sulcus. So we can titrate the biometry according to the sulcus placement. Now this is a study whereby I do not place single piece lens in the sulcus. I have done it so that no eyebrows are raised. Therefore, I have to put in multi-piece lenses. But lenses can be designed with a trifocal optic with, like the resume and all that. It is possible to design. So the industry can have a think that, of designing it that way. It's a question of lens design. And effective lens position is defined here, is the sulcus or a little below that. So we can titrate it. And PCO remains to be seen. Even with acrylic premium lenses, we have lots of PCO, no financial, particularly IQ, there's so many. Yes, PCO is a concern, I agree. But my question here is to address the negative dysphotopsia, which is very high and annoying. That's what I have been trying to address here. So, and the incidence is really less. And we can try it out, anybody in our normal setup, no extra thing done. We don't need to do YAG, not this cutting of the IOL inside the bag, not a secondary procedure. It can be done as a primary procedure. Yes, any questions?
Any more questions?
Just one question. So how do we select the patients? We don't know whether this patient will go for a negative dysphotopsia. It's only after you have given the IOL. Suppose I've given a premium IOL. So how do I have to either replace it or I do a optic capture? So how do I know and plan beforehand giving him a 3-piece? That is the thing. You have
No,
done
no,
a
it is-
study.
it is
It's fine. The study is fine. I'm saying. So it's like we are going back to giving 3-piece IOLs.
No, like we had multifocal IOLs with 3-piece IOLs, like resume and all that. So maybe the newer trifocals, some company can come up with this 3-piece design with a premium optic, and we can give it a try. It's no way we can judge it
Yeah.
beforehand because everything is unknown.
Yeah, thought
But these
process
results
is, yeah, thought process is fine, thank you. But what sir was talking about that Marie-Tagisian's lens that we use in pediatric cataracts, but it is not very common over here. So she has done a very good study in Belgium. So that lens has a very less PCO, and that can also take care of this negative dysphotopsia.
Yes,
th-
I have
that
other
has a
thoughts
little
in mind
surgical
also.
difficulty, that technique is little difficult.
Yeah, difficult.
But the concept keeps changing. Like sulcus implantation was the initial our thought. We all shifted to in the bag implantation, thinking that is a much more physiological space. And coming back to sulcus again, it requires a rethinking.
Not the haptics in the sulcus, optic is still in the bag.
Because haptics are the one which are main concern. They are going to rub against the entire posterior area. Depends on what is the anatomy of those people. Never know these haptics may be touching the posterior part of iris, uveal tissue. Sometimes they may
That's why I
against
did it with multi-piece
We
lenses
need
for
to
the
do a
time being.
long-term study to see what are the hidden inflammation happening in these
So I
patients.
think I need ethical clearance for
Yeah.
placing single-piece lenses in the sulcus with optic captured in the back. I'll do it in due course
Yes,
of time.
again, that's the single piece also very difficult to fix like
Yes.
that.
Even the post-operative opacity almost became slit-like in the long-stand patients.
It is 1 year almost, nearing 1 year I've done this study. Not much, not so something alarmingly significant which we don't see in our day-to-day practice. It is not that all this are coming, running to for an OPC.
As a retinal surgeon, I will be concerned about my visualization of the periphery because it's now becoming slit-like. The patient's visual access may be still clear.
No,
not
no
with the
patient complains about that little bit of opacification of the rhexis margin. That is not complained about.
Thank you.
Thank you so much.
Vinit, you have a question? No,
This is
okay.
basically the treatment for negative dysphotopsia.
Yes.
So if you have it, you do it.
This is definitive
This
treatment.
is like prevent.
And somebody, if he or she is having it in one eye, you don't
Then
want
you
to
can think of
brush
it in
him
the
the other
other
way
eye.
around, and then in the next eye you want to be dead sure. So I think this is a technique to go for, hands down.
Thank
And
you,
you,
Dr.
SK.
Devashish.
Thank you, sir.
Can I request Dr. Girish Rao sir to please give a certificate of appreciation to Dr. Devashish? Next, we would like to invite Dr. Neeraj A. Israni, who will be speaking on universal slit lamp adapter.
Very good morning. So my topic is universal slit lamp imaging system. There's a video, so I'll start the video. That's my patent, and it's also FDA approved.
Mandatory,
Can we have the volume,
not
please?
only for patient education, but also to safeguard a surgeon from unnecessary litigations. The pre-existing slit lamp imaging adapters that are available in the market are either very cumbersome to use or require holding the slit lamp adapter and the phone together using both our hands. On the other hand, slit lamp adapters with beam splitters are very expensive. Introducing the US FDA approved and patented universal smartphone based slit lamp imaging adapter. The device has been designed keeping in mind the cost effectiveness and to help digitalize your slit lamp to capture images to educate patients about their conditions. You will find all the components in the box. Slide the base of the adapter onto the rotating arm. Attach the smartphone holder on the base and lock it in position using the knob. Attach the smartphone on the phone holder. You can use any smartphone of your choice. The device is compatible with majority of slit lamps. The device has a unique design that enables it to be mounted on the handle of the slit lamp and can be rotated in and out with the patented swivel technology. One can align the smartphone camera to the right eyepiece of the slit lamp. The distance between the smartphone and the eyepiece is typically 3 to 5 millimeters. Fix the assembly on the slit lamp by tightening the screws. The device is now permanently installed on the slit lamp. The operator is now doing a routine slit lamp examination without any interference. Then he rotates the device into the right eyepiece of the slit lamp. He can then open the camera and capture images or video of the eye. Once the image is captured, you can print them and also show it to the patient. Our device has various advantages over the other devices, such as it is cost effective, it has a universal slit lamp compatibility. Not only it has a universal mobile compatibility, but it can also be used for telemedicine as it is extremely easy to use. Thus can also be operated by an optometrist. Using any screen mirror application, the video can also be portrayed on a television, thus helping the patient and the relative understand the condition better. Here are some of the images that we have captured in the last few months.
Thank you. So I have the device with me over here. It's made out of ABS plastic, which is the most common medical grade device that is used. And as you can see, this basically goes and attaches to the handle of your slit lamp, and there is a swivel. So as soon as you want to capture an image, you have to just bring it in front of the right eyepiece, and it is permanent, so you can keep it attached to the slit lamp for the entire time. You don't need to remove it again.
Thank you,
What is
Dr.
the co-
Neeraj. Please go
Sorry?
ahead. Please go ahead.
Because it is made out of ABS, it is slightly expensive, but it will go up to say 7 to 8,000 rupees at the most, not more than that.
And do you have a way that you can connect it directly to a monitor?
Yes, sir. So see, any mobile phone that you're using these days, there are so many applications which you can screen mirror. So you have a TV, any smart TV, there's a screen mirror application. So whatever you're seeing over here, with the help of screen mirroring or a simple Google Chromecast, you can put it on the screen. You can just project it. That's what I did.
I think it's a terrific device.
Thank
What
you.
about doing some sort of procedures? Can it also be documented? Like suppose I want to do a 90D.
Yes.
Will that hamper my?
Sir, because it is just for capturing images, so while doing a 90 diopter, you have to obviously move it away. But I have tried removing a foreign body looking into the camera screen. It works well. 90D to a certain extent,
Because
you need that judgment.
Because your thing is coming right onto the ocular, I can't see through
Yes,
that.
sir. So 90D, it does take little time to adjust, but foreign body removal is very easy. So I usually, what I do is I remove the foreign body and then Chromecast it. So the patient is much more comfortable and happy because they do know that there is a foreign body. Otherwise, invariably, they don't come to know, the relative doesn't come to know.
Player or save.
So it depends on the camera. So if you have that high magnification camera, any phone can be used. So a good phone like the latest advanced phone with very high optics, you can do even, so I have also done one simple image of capturing the endothelium cells using a Samsung Galaxy S24 with this. I have not put it, but then you can even capture with 50x magnification.
I've got S23. I can capture.
Yeah, yes, sir. S23, S24 both can capture.
Thank you. Can I request Dr.
Thank you,
Sucheta ma'am to please give a... Next, we would like to invite Dr. Karishma Tendulkar, who will be speaking on breaking barriers, evaluating macular edema on portable, low-cost, high-performance spectral domain OCT. Dr. Karishma, please.
Thank you, sir. Good morning, respected judges. Good morning, everyone. I'm Dr. Karishma Tendulkar from Narayan Nethralaya, and today I'll be discussing the utility of a portable, low-cost, high-performance ST-OCT in evaluating macular edema. As we know, the OCT is an indispensable tool for every ophthalmologist today. From its inception in the 90s as a time domain OCT, it has undergone several reiterations and improvements to its current form as the SSOCT. However, in spite of these technological advancements, we see that there is a limited access of this technology to people in rural areas and camp settings. This could mainly be attributed to the high cost and the bulky design of the OCT machines. So how do we overcome these challenges? With this in mind, we at Narayan Nethralaya, in collaboration with Artelius Bangalore, came up with a low-cost, high-performance ST-OCT with an inbuilt retinal layer segmentation software. So this has a handheld OCT which is mounted on a chin rest stand. It comes with a console and a touchscreen laptop with a Wi-Fi and USB which enables sharing of the data from secondary referral centers as well. So it's literally an OCT that can be carried in a bag. It's only 3.9 kgs. Coming to the technical specifications, it has an axial resolution of 5 microns, a lateral resolution of 19 microns, depth of imaging of 2.7 millimeters, and a wavelength of 840 nanometers. So this, as we can see, is comparable to the Spectralis Heidelberg, which is the standard OCT, SD-OCT that we use, and we use the same machine to validate our machine against. And you can see with all the specification, it only weighs around 3.9 kgs. The system also, we also developed the retinal layer segmentation software along with it. So what it does is it can delineate the retina from the ILM to the RPE. This is an OCT report from the machine. So with this, we carried out a study. It was an observational, cross-sectional, comparative study in 50 eyes with clinically diagnosed macular edema. Of course, we excluded the eyes which had media opacities or fixation problems like nystagmus or squint. And we carried out the scanning on, we carried out the scanning on, So we carried out the scan on the two machines and compared the results. So what did we find? We basically evaluated the two machines on the image quality and the macular edema parameters. As you can see, the images on both the machines, the one on the right side of the screen is the LCHP and the other side is the SD-OCT. And we can see that it's comparable. We also saw that the retinal layers were very well delineated. As we can see in the first image here, the retinal thickening is seen. There are hard exudates that are seen, and also we can see the photoreceptor layer disruption. In the second image, we can see a pigment epithelial detachment. We could also note a few OCT biomarkers like drill changes, that is the disruption of the retinal inner layers in the picture that you can see, the red arrow above, and subretinal fluid. The VR interface abnormalities such as an ERM and VMT were also well noted. However, there was limited visibility below the RPE. As you can see, the Spectralis image shows a better imaging of the choroidal vasculature as opposed to our machine. Also, the machine did have a few additional artifacts because of which the imaging was not very good quality. However, the macular edema parameters on our machine and the Spectralis were both comparable. So how does the LCHP OCT perform against the other low-cost OCTs? So this is an indigenous built OCT with an automated retinal segmentation software and has a better axial resolution compared to the other OCTs developed by the Song et al. Group and the Kim et al. Group. So in conclusion, I'd just like to say that the OCT is comparable to standard OCT technology. It's portable, economical, it can be used as a screening tool, especially in camp and rural settings, and can also be used for telemedicine and referral from non-ophthalmologists. So I have a short video here which shows how the OCT can be carried in a bag and can be taken to rural centers and even for camp settings. Thank you.
Thank you, Dr. Karishma. Judges, please.
I think it's a great innovative tool, especially for home monitoring or for the rural screening. I just wanted to know what's the cost of this?
So it's around 13 lakhs.
13 lakhs.
Yes.
Okay.
Which
and
is,
in terms of reproducibility of the images?
so as in
For follow-ups, how?
Yeah, so the machine does have the laptop that I mentioned. It has a USB and a Wi-Fi, and it also has facility to store and share the data. So if the imaging is done at a rural center or a referral center, this can also be shared with a ophthalmologist in the city. So that is one of the features that is incorporated in the system.
So most of the machines do have a follow-up criteria where it takes the data of the previous scans
Right,
and does
yeah.
scan the same area
Yeah.
to give you the comparative.
Yeah, I
Does
don't
this
think at this point it's not there, but I'm sure in the future we'll develop the facility as well.
Thank you.
Thank you, sir.
Thank you so much. I'd like to request Dr. Manavi Sindel, ma'am, to please give a certificate. Next, we would like to invite Dr. Kunal Mandik, who will be speaking on LumiZoom.
Thank you, AIOC and judges, for giving this opportunity. So my topic will be LumiZoom. LumiZoom is an innovative device which we may use. Just one second.
Year of surgeries at Aravind Eye Care System looks like. Majority of surgeries are done under subtenant anesthesia. Subtenant anesthesia involves making a small nick in the conjunctiva and tenons capsule. Anesthetic fluid is then injected into the subtenant space. This procedure is repetitive at our center due to high volume. It also involves small working field and requires precise skills. An effective subtenance block will make a surgery smooth and seamless procedure for patient as well as the doctor. A good subtenant block requires a good ergonomics, better visualization and proper illumination. The device currently available provides good illumination, but lacks magnification and good ergonomical design. This often leads to complications such as congestion, chemosis, subconjunctival hemorrhage, and inadequate anesthesia. As doctors, we also face headache, neck pain, and body ache. We propose to solve this problem by giving you a spectacle for good ergonomics, a magnifier for better visualization, and a headlight for proper illumination. Not 3 different products, but a single device. Here we introduce to you LumiZoom. LumiZoom can be worn by anyone, including people with spectacles. A pair of plus 1.5 diopter lenses is used, which provides reasonable amount of magnification for a working distance of 40 to 50 centimeter, which is ideal for administering the ocular anesthesia. The LED diode provides ample illumination to the field and can be tilted as per user's convenience. It is powered by 2 lithium-ion batteries that are attached to the frame. It is rechargeable and it is charged wirelessly by a magnetic attachment. We estimate that it will provide a battery standby of 4 hours in the high luminance mode and 10 hours in low luminance mode. To test our LumiZoom, we asked 8 doctors to use it in our wet lab. All of them reported adequate magnification and illumination. 3 of 8 doctors reported a loose fit of the device. This was then corrected using an elastic band attached to the rear of the frame. All of the users said that they would recommend it to their colleagues. This device can be used for multiple other applications that require good illumination with magnification, such as low vision aids, microelectrical work, dentistry, surgical applications in low resource settings, and the list can go on. Thank you.
Thank you, Dr. Kunal. Judges,
Thank you,
please.
sir.
The topical exercise नहीं करते.
These are all topical surgeons.
Mainly in Arvind we do SICS, so for those SICS now we have shifted to almost 100% in subtenon's anesthesia, not peribulbar. So that's why our PGs who are posted in the block rooms, they face difficulties like what I mentioned in the presentation. So to deal with that, we come up with this idea during our hackathons, yearly hackathons which we organize in Arvind. So mainly our loops are also there and headbands are there, but they are little cumbersome, they cause headaches. So we wanted a device which can be worn like a spectacle, easy to use. So that's why we came up with a routine protective glasses which we give to the patient to attached 1.5 diopter lenses with lithium ion batteries, and those are wirelessly chargeable. So we just have to keep it on the box charger that will be charging. And in the first prototype, there was an issue that the PGs who used, they faced that it is dropping because of the weight. So we attach a headband, but now in the second prototype, we are making the earpieces slightly heavier on the back side. So it will grab the, balance out the weight of the lights and system.
Can this be used in emergency
There are
departments
many-
where there is lid suturing and all?
Yes, madam. And in the next prototype, we are updating it with the interchangeable lenses. So we can increase the magnification also from the side. So that will be useful in low vision aids, the emergency ERs, and along with the block rooms and everything.
Have your plastic surgeons used it, the oculoplasty surgeons?
Not
or
yet
along-
right, sir.
Not yet right. And what's the cost of the device?
It is very cheap, sir. It comes to around 1,000 or less than that, because the 2 lithium-ion batteries and all those stuff are available in regular electrical stores. Those are around 300 milliamp hour batteries. So it's and this innovation has won CII Innovators Award this year also.
Thank you.
Okay, we'll move on to the next presentation.
1 minute, he wants to ask something.
Millimeter working distance. So that means you have to go 6 centimeter in front of the patient.
That
You
was-
were
that wa-
far away. You were at least
Yeah.
maybe 1 foot away
Yeah,
from the patient.
that was the first prototype which was done in the hackathon. So the next prototype which we I
Which is
spoke,
going to
that is no, we have already it's under production. We are it has an interchangeable lenses.
So you will have
So-
to go up to maybe say around 14x to
Yeah.
get that kind of a working
Yes.
distance.
Thank you. Can I request
Thank
Dr.
you, thank
Vineet
you.
Ratra sir to
Thank
please
you,
give
sir.
a certificate of appreciation? Next, we would like to invite Dr. Pratibha Devi Nivian, and she will be speaking on tier biomarkers to predict activity, South Indian Thyroid Eye Disease Study. Dr. Pratibha, please.
Respected teachers, judges, and colleagues, I am Dr. Pratibha Devi Nivian, and I'm here to talk about tier biomarkers to predict activity, a South Indian thyroid eye disease study. Thyroid eye disease, as we all know, is an autoimmune disorder. The pathogenesis and understanding of the pathogenesis is evolving. There are a lot of newer targeted treatments which have come and have been successfully proven to be treating the activity of thyroid eye disease. We know thyroid eye disease has varied stages from simple mild lid retraction to a very dreadful, visually debilitating disease with dysthyroid optic neuropathy. What do we do? Current scenario, we treat the patient based on the clinical activity scoring or the VISA scoring and treat them with high steroids or immunosuppressants after the disease has become very active. What is lacking is we treat after the disease has established very well when we have lot of targeted therapies already existing in the market. So I did some literature search. I found that there were a lot of researchers in this aspect which was done to find biomarkers causing activity and severity in patients with thyroid eye disease. This particular article was very interesting in Biomolecule Journal, where they have done a meta-analysis and they have compiled the work done in tier biomarkers on thyroid eye disease, and they have come up with certain inflammatory cytokines which have been elevated in thyroid eye disease. And on the other hand, I did find that there were a lot of targeted therapies which have been already currently being used after randomized controlled trials, proven to be very effective in active eye disease. So what could have been ideal is to identify the patients who will probably develop a disease based on molecular analysis and treat them before they develop the disease. So where do we look for biomarkers? We can get it from any human tissue, but tears is very easily accessible and it is non-invasive. And so why here and think under the apple tree this topic is just tweaking the thought process in management from the existing guidelines, probably to look for biomarkers causing activity in thyroid patients and treat them early before the active disease could reduce the morbidity in such patients. But as of now, in India, we do not have any background data about the thyroid tear markers. So we aim to find significant markers that cause severity and activity in thyroid eye disease patients. It was a pilot study done prospectively after ethics clearance. We did take the tear samples from 2 tertiary care centers. Schirmer strips were used. We included patients with eye disease, without eye disease, and healthy controls. We performed multiplex ELISA and we looked in for the inflammatory markers, the cytokines, which were already been proven in literature to be elevated in thyroid eye disease. And this was the result. We found that most of the inflammatory markers were elevated in patients with thyroid eye disease compared to patients without thyroid eye disease in spite of having systemic thyroid dysfunction. However, we found a statistically significant increase in the values of interleukin 6 and interleukin 10, which made us think that probably interleukin 6 and interleukin 10 could be a potential cause for a disease development in thyroid patients. So just by tweaking the therapeutic approach, like looking for markers in patients with thyroid disorder and treat them with specific antagonist early in the earlier days, could probably prevent them from developing a bigger proptosis or a visually rehabilitating condition. So to conclude, finding the most vulnerable candidates who succumb to the disease would reduce the morbidity, and this works as a prevention and could avoid high-dose steroid treatment. I would like to acknowledge the people who helped me during this journey. Thank you.
Thank you, Dr. Pratibha. Judges, please.
Interleukin 6 and interleukin 10, the ratio is increased in the particular interleukins 10 and 6 in various cancerous diseases like primary intraocular lymphoma, where you get IL-10 high and IL-6 low. Your finding, I don't know that whether this is an inflammatory marker or a kind of a biochemical marker of this presentations. So thyroid is an auto-inflammatory disease.
Yes, sir.
Okay. So what is exactly the role of
so, sir, my thought process was in thyroid patients, if the tears shows a higher levels of interleukins, probably those are the patients who would probably develop thyroid eye disease. So those patients would need a closer follow-up. And if the value is more high, probably they should be started on specific antagonist with like interleukin 6 antagonist rather than giving steroids after they develop an active disease. That was my thought process, sir.
What was the cutoff level of interleukin 6? Like, what was the value which will say that this will be going for the thyroid eye disease?
Ma'am, there is no specific guidelines available as of now, ma'am. We have to go a long way to find out.
Did you do the analysis and did you find out anything in that? Only you are showing that it is increasing, but there are other things which is going on also. So have you seen that, or have you seen in the serum if anything is coming? Because these patients are also in the endocrine, if you work with them together, you can get something. So that is what I am just suggesting.
This is just a small pilot study. There's a small start.
And how did you take the tears from them?
Schirmer strip, ma'am.
Okay, so
we took Schirmer
basically
strip.
it is a biochemical test you have done.
Yeah,
that is what we are
multiplex
talking
ELISA was done.
Yeah.
It was stored in -90-degree refrigerator. It was transported to a lab where they do this paneling testing.
Thank you, Dr. Pratibha. I'd like to request Professor Jeevan T.T. Alsat to please give a certificate of appreciation to Dr. Pratibha. Next, before I welcome Dr. Anupama, I'd like to welcome our former ARC chairman, Dr. Chitra Ramamurthy, who is here with us. Welcome, ma'am. Next, Dr. Anupama Bappal will be speaking on innovative 3D printed B-scan working teaching model. Dr. Anupama, please.
Thank you, sir. A very good morning to all. So my journey in ocular ultrasound began as a postgraduate student and then as a retina fellow. It took a little while for me to kind of master the technique and interpretation of B-scan, but eventually as a teacher, it's my responsibility to teach my students the B-scan in a very simple way. So B-scan is a very essential investigative skill a postgraduate student should be able to perform. And the challenging part about B-scan is the ultrasound is invisible. So the student is unable to see where exactly the sound is falling in the eye. And at the same time, to convert the 2D image to a 3D imagination is a little challenging for students. So what we did was we replaced the invisible sound with the visible light waves, and we started it from scratch. So I took the tissue roll, I placed and I took this plate with this little aperture which you would find in an Indian kitchen. So we put it together and we got this slit illumination. So all you need is a source of light, a tissue roll, and a slit aperture, and then you get the slit illumination here. So now to understand the different technique of B-scan, that longitudinal, how to hold the probe for a longitudinal transverse scan, and which part of the retina is being scanned during this technique becomes very easy to understand. So we wanted to refine the B-scan, so that is when, this prototype, so that is when we designed a 3D B-scan prototype, and this is what we got. So you can see this video which shows the positioning of the probe for a longitudinal scan. It's so beautiful to see that, the student can also visualize the area of the retina being scanned for these longitudinal transfers and axial scans. So the learning becomes very simple. And the interesting feature of this B-scan prototype is now whatever is being scanned is also scanned is also captured on the screen. So hence the students also get understand the concept of the area corresponding to the marker is seen superiorly on the screen. So when we took feedback from students, we got a very good feedback from students. It was quite encouraging. And when we assess the retention of technical skill, majority of the students could retain the technique of performing B-scan and interpretation of B-scan. So, and B-scan should also be included in a simulation-based curriculum in ophthalmology. So I end by saying that this is a very effective model to teach fundamentals of B-scan, especially the technique of B-scan. It gives tactile experience to students, and teaching and learning becomes much, much simpler and easier. Thank you.
Thank you, Dr. Anupama. Judges, please.
Interesting idea, and I think when we use it, we'll really understand the practical, but from the students' feedback, it does seem to improve their...
So because in chapter in book would be about 4 to 5 pages, to read all of that and to kind of assimilate it and do it becomes a little difficult. It was difficult for me. So when I taught my students, I wanted them to learn it in a very simple way, and this they learn it in just 5 minutes.
So it does help in the orientation of the anatomy.
Yes.
But the interpretation into 3D is still a challenge.
Difficult. No, but at least they know that which part of the retina is being scanned, and it's easy for them to convert 2D image to a 3D imagination.
Thank you.
Yeah, thank you, sir.
Thank you. Can I request Dr. Jyotirmay sir to please give a certificate of appreciation to Dr. Anupama? Next, we would like to invite Dr. Malika Arjun M. Heralgi, who will be speaking on cannula for hydroimplantation of IOL. Dr. Malika Arjun, please.
Good morning, one and all. Basically, implantation of IOL in the capsular bag under the irrigating solution without viscoelastic. That is the aim of hydroimplantation of IOL. What is the need? Retained viscoelastic after cataract surgery can cause post-operative inflammation, raise intraocular pressure, sometimes stars, leading to patient discomfort and delayed recovery. Few surgeons use IO probe, but which cannot be used by those who are using coaxial IA, because I did a small survey in WhatsApp. Around 52% of the surgeons still use coaxial IA. And some people, they use hypodermic needle, but it may cause all the injuries to the intraocular structures. But so there is no specific device available. This is a hydroimplantum cannula which I devised. It is a basically 20 gauge stainless steel cannula, and tip is blunt, and there is a hole at the bottom, and as well as there is a hole at the side of the cannula. So usually what happens, the fluid, when it is connected, it comes at the bottom and inflates the bag, and side port will form the antechamber. And these are some videos where this cannula is used. As soon as you insert it, the ACs will be very well formed, and till the procedure, completion of the procedure, AC will maintain tightly, unlike you use in viscoelastic, which will come out continuously. And this can be, this is how it is used. This is the cannula, and it is connected to the irrigating fluid, and in other hand, we can inject the IOL. The most important thing is it can be used in SICS also. So it can be inserted to the side port, and it can be tied to the limbus with the help of bolster, and the whatever IOL is intended can be implanted. And you can see the fluid is continuously coming out, even though the antechamber is nicely formed. And most of the maximum surgeries are done in India by SICS. And few surgeons in a complicated cataract, they do SICS and implant foldable IOL. There can also be, can be used. And in cases like where there is a screw type of injector, this cannula can be attached to the limbus with the help of bolster, and both hands can be used for the implantation of IOL. Even in cases of toric IOL, this cannula can be used, and one advantage is this cannula can be used as second instrument, and the IOL can be manipulated with both cannula and other instrument. Then why not you use an AC maintainer? AC maintainer has its specific function that it maintains the antechamber, that's all. But hydro implantation cannula can be used as second instrument. In what happens in hydro implantation, the IOL unfolds slowly because of a glass transition temperature, that is TG. Higher the TG, the faster the unfolding of IOL, that is in visco, and lower the TG, slower the unfolding of IOL, that is under BSS. So this can be used to IOL manipulation, opening the haptics, avoiding flipping of the IOL, manipulation of toric IOL implantation. This is one example. After the implantation of the IOL, the IOL unfolds slowly, so the cannula can be used for unfolding it. So we did a study, and a small study where they divided into two groups. Group one had 20 eyes, and group 2 is 20 eyes. In the first group underwent phacoemulsification, second group underwent MSICS. A learning curve was only 2 eyes, and IOL implantation was easy in both groups. These are the immediate post-operative images. In conclusion, cannula helps in smooth implantation of IOL, can be used in phaco and MSICS, and this is the first of its kind in available. Avoids post-operative visco-return complications and reduces the surgical time. And both hands can be used to implant IOL. Thank you.
Thank you, Dr. Mallikarjun. Judges, please.
I think hydroimplantation is in vogue. Many people do that, and they have devised various ways to increase the infusion coming from the side port. Good technique, and people mainly look into for toric implantation more of and in phakic IOLs also. Good technique.
Can I request Dr. Girish Rao, sir, to please give them... Can I request our former ARC chairman, Dr. Chitra Ramamurthy, to please come on the stage to please honor our judges and panelists who are here. Dr. Chitra Ramamurthy, ma'am. Dr. Vineet Ratra, sir. Dr. Manavi Sindel, ma'am. Dr. Sucheta, ma'am. Dr. TTL, sir. Dr. Jyotirmay Biswas, sir. Dr. Girish Rao, sir. Can we request all the presenters to please come up?
Dr. Satyajit Sinha.
Thank you. That brings us to the end of the session. Can we have all the presenters please come on the stage, please?
Light will not reflect.
Okay, okay. See, you want a good photograph.